Speaker to talk about the analysis of missed cervical spine injuries is a friend and colleague of mine, Dr. Wendy Cohen, a professor of radiology and co-director of the neuroradiology service here at Harborview, a person that I work with every week to review films, and have grown to respect her thoroughness, understanding, and wisdom as it relates to neuroimaging. Dr. Cohen.
Thank you, Dr. Herring. What I want to talk about, and what I'm going to show you, are a couple of cases of what is hard to see. We do really well, but there are still things that are a little difficult to see on films. What we do see, there are two relatively recent studies that have looked at misses, and misses are defined now as delayed diagnosis, because the only way you know you miss is if the diagnosis is made later. So the definition of a miss is truly delayed diagnosis. This study came out of Pittsburgh. Daphner looked at over 5,000 patients. 297 of them had cervical spine injuries. This is the cervical end. 245 had complete charts that they could review. It's retrospective. And they looked at the imaging diagnosis. And what you get is something that we've all come to realize, is that CT is really accurate. If CT shows, it will show most of the fractures. It doesn't show all. It will show a huge number of them. It doesn't show a fracture if somebody has a SOARA, which is or a spinal cord injury without radiologic abnormality. They're not usually like Dr. Franz's. They're usually more of the patients who have really bad cervical degenerative disease and big osteophytes. And then you have somebody who's got a cord contusion and no spinal cord injury, no spinal cord osseous abnormality in terms of fracture. But you've got somebody who's abnormal because you have an abnormal clinical exam. So back to it. There are lots of old discussions about how many films to take, whether you take APs, whether you take laterals, whether you take obliques. Radiographs still are going to get less than half of your fractures, and CT is going to get almost 100%. What you miss on CT are fractures in the plane of the section. So if you have an axial plane and an axial plane fracture, like a Dens fracture, a type 2 Dens, or in the other case, the other one they missed was somebody who had big dental artifacts and the reconstruction was not very helpful. But most of the trauma series now will have patients come in and get a single lateral before they get their CT, and the single lateral picked up both of those. There is one other study that looked at thoracolumbar spine. They looked at 181 patients with thoracolumbar fractures. That group actually had about 300 defined fractures. 43 of those patients had delayed diagnosis. This group's a little more problematic because it's a harder area to see. These were mostly polytrauma, and where we also run into problems are the patients who have multiple injuries and have to go to the OR now. You go to the OR now, you don't get x-rayed. You don't get x-rayed, we don't know about the fracture. We now currently are doing big combination CT series so that when you get your chest, abdomen, pelvis, total body CT to find out what your soft tissue injuries are, we're also getting the spine CTs out of that data set. So that I think this number, if you do a retrospective review from about now and the multi-slice scanners, 10 years from now, we may find that that number has gone down. I hope. As you know, the huge proportion of these patients were polytraumas, and that's the biggest group that was missed. They didn't get filmed. 7 people actually had exams that were missed, and 3 of them were just not considered sick enough to need filming, and were just discharged without getting films. There are 2 sets of cases. This one is actually in the cervical spine. On your far right is I don't have a plain film, I have the scout from the CT. In the middle, you've got the cervical spine reconstruction, and on your left, you've got the axial image at the appropriate level. Where is the fracture?
Just looking at your middle picture, I would assume you've ankylosed the anterior longitudinal ligament, and there's possible disruption through what I think is going to be the C5-6 disc pegs, which would be an axial fracture.
Give this gentleman a gold star. You're right. So this is an ankylosing spondylitis, and there's the fracture. On the far left is now the MR, and This is where MR is useful. MR is not a primary imaging technique. MR is a sort of adjunct technique to help us solve problems. It's really useful in the ankylosed spines. So this patient has a spinal cord injury, has a area of increased signal intensity in the cord right here. There is the fracture line, but I have actually a better image for it. I have the mag. It's a very subtle fracture. So these are extension injuries. These patients come in with basically minor injuries and fairly soft bone and just fracture with little injury. Diffuse spine, the underlying pathology is usually ankylosing spondylitis, DISH, or just a degenerative spondylosis with fusion. They usually have minimal trauma. They're potentially occult, potentially are usually unstable. May have epidural hematomas associated with them, which is one of the other reasons to scan these patients because the bone does bleed. CT is going to be your primary study. This is one of the few studies where I think you need to do MR earlier and not just rely on the CT to get you through the first part, because I think you will miss stuff. This is another example. This is a 76-year-old who just fell getting out of bed. These are patients who will come in not into the medical center. They're going to come into community hospitals. And he has a fracture there, easier to see on the CT scan. But they come in with back pain and they may or may not have a neurologic deficit, but the problem is these guys are really unstable, and if they move, you can go from an intact patient to somebody who is non-functional and not walking. This is the polytrauma end. This is a 35-year-old who was transferred in here following a motor vehicle accident 4 days after the event. He was moving all extremities weakly, right worse than greater than left. Now, this guy is intubated, he's a polytrauma, he obviously has some cord injury, he is alive. Where's the injury? He's an Atlanto-occipital dissociation. People do survive this. Let me go through this. There are a lot of rules for looking at this now. The ones I found most useful and what we all tend to use now were described by Harris in the mid-90s. Basically, all you need is a lateral plane film. You have it on your first trauma image that you're going to get. It's easier to read on a CT, but you have it on your first film. There are a couple sets of lines you need to look at. One is you look at the distance between the basion and the tip of the dens, which is this point here and the tip of the dens. Admittedly hard to see sometimes. It should never, in an adult, so this has been validated in patients over 12 or 13 years of age, be longer than 12 millimeters. 12 is your magic number. So basion dens interval is always 12. There's another numbered line you can draw, which is a line that goes from up the back of C2 called the posterior Atlanto line to basion, that PALB line. The basion is either in front or behind it. It is in front of it no more than 12 millimeters and behind it no more than 4 millimeters. This works. This works consistently. If you looked at this gentleman, he was not distracted longitudinally. That was only 8 millimeters, but he was displaced anteriorly. Not a lot, but enough. Actually, CT is easier, because when you get your CT reformations, what you can do is look at the occipital condyle to ring of C1 junction, and it should look like a cup. But what you have here is in the middle one, there's a gap. And if you look here, there's a gap. Now this is more of a unilateral than a bilateral, but remember, this patient is still with us and will survive and will recover. The other is another trick when you see distraction injuries, just look for the absence of bone. Pretty much on axial images in the spine, you should see bone on every image. And if you look on this particular patient, this one has a different patient has a bilateral. There are a couple images here, here, and here where there's just no bone, and then you get to bone again. If you're missing bone, there's a distraction injury, and even if you're just going through the first CT scans before the reformations go in, you've got to start sort of worrying. The other thing, and this is something that a lot of the orthopedic surgeons are just learning because we're all just learning this, there's been a lot of work over the last 8 to 10 years over vascular injuries associated with spinal cord injury, and in this particular patient, there is an injury to the vertebral artery. If you look on to the right vertebral artery, it's thin and irregular, and this patient came in with a subarachnoid hemorrhage and a vertebral dissection. So in conclusion, CT will show you most injury. You have to have a high index of suspicion in specific populations, in particular the ankylosed spine, and MR is useful to clarify the subtle injuries. Thank you.
Thank you very much, Dr. Cohen, for reminding us of the importance of being thorough. In this next section on diagnosis, we're going to talk about the role of the surgeon in spine clearance, and then that gives me the opportunity to ask Dr. Brian Kwan to come forward. Dr. Kwan well known for his academic and clinical work in spine research, is visiting with us from Canada at University of British Columbia. And there you are. It's all yours, Brian.
All right, thank you.
All right, thank you, and good morning to you all. And I want to extend my appreciation for the invitation to come. It's a great honor to be included in this program. This is going to be a discussion about the issue of cervical spine clearance, issue that certainly faces us routinely. The issue of cervical spine clearance is really one of risk management. So this whole topic is about risk management. And so this person indicates, be careful. All you can tell me is to be careful. So that's kind of what the sum of this entire lecture is going to be about. And really what we're interested in is this question: how do I avoid making this patient who comes in, who we might not necessarily be able to examine, a quadriplegic? And so this is a balance. This is a balance between missing an unstable injury with potential neurological consequences versus the cost and morbidity associated with the investigations to rule that out. To guide us in this is a balance between the scientific literature that is growing and clinical experience. So I'll try to describe a little bit of both. And really, there are two distinct clinical scenarios to consider in this situation. That is either the awake, alert, and cooperative patient, and secondly, the unconscious and obtunded patient. In this patient, the question really is who warrants an investigation radiographically, versus in this patient, the question is really who warrants more than just a CT scan. So who actually warrants radiographic investigation, or really the question could be phrased as who is actually low enough risk to not investigate? This is a question that is being really addressed extensively in literature and has been the genesis of the Nexus criteria and the Canadian C-spine rules. These rules are ultimately about risk management. These are not rules to identify those patients who do not have a cervical spine fracture. These are risk management rules, because when you look at the actual Nexus paper, the Nexus paper actually shows the number of patients who they actually did not identify using the rules, and in fact describe the 8 patients who were found to have a cervical spine injury despite being classified as low risk. Now, having said that, it only took a couple years before the Canadians decided to do a comparison between the Canadian C-spine rules versus the Nexus, and I think the gist of this is that these rules are really very good at predicting who does not need a cervical spine film. Both have excellent negative predictive value. They both have poor positive predictive value because the patients that are really low risk actually have a very low prevalence of having a fracture. In the end, this analysis indicated that the Canadian system is actually better, which is just our Canadian inferiority complex reigning through in the academic literature. So then becomes probably the more interesting thing for us as spine surgeons, that being the obtunded, because we're not usually the ones that are deciding who is and who isn't going to get an X-ray in Emerge. We're the ones that are being called upon to try to figure out what to do with this patient who's in the ICU, who's intubated and really not able to give us an exam. So the questions really here are what imaging is necessary, and also what are the risks associated with waiting for that imaging or doing that imaging. And I think this is probably the best way to summarize. This is an evolving field of study, so there are no absolute answers in this yet. And here is an example of that evolution. So in the 1990s, there were the East guidelines on cervical spine clearance. I'm going to just show you a couple of the guidelines. This is one of them. If the cervical spine radiographs are normal, but the patient complains of significant neck pain, cervical spine radiographs with the patient actively positioning the neck in extreme flexion and extension should be obtained. And we know that now that this is actually not the case, because patients with significant neck pain simply don't give a good flexion extension X-ray. And so these are actually invalid. And that's been well demonstrated. The next guideline is that trauma patients who have an altered level of consciousness may be considered to have a stable cervical spine of adequate 3-view plane radiographs, CT supplementation as necessary, and thin-cut axial CT images through C1 and C2 are read as normal by an experienced physician. And so when you look at this, it's fairly obvious that this is no longer sort of what we consider to be true. Now, I think one of the things that came out of the East was there was a recommendation about doing dynamic fluoroscopy in the intubated patient. And one of the studies that really championed this was by Jim Davis and his group. And in this paper, Clearing the Cervical Spine in Obtunded Patients, the Use of Dynamic Fluoroscopy. And they concluded in this study that dynamic fluoroscopy provides a safe and effective method of determining cervical spine stability and allows early removal of the cervical collar after a normal study. That was published in 1995 and actually was one of the studies that led to those East recommendations. 6 years later, they published the reappraisal of this technique. And in this, they described 1 out of their 301 patients who were cleared with dynamic fluoroscopy that did not adequately view the lower cervical spine. This patient was rendered completely quadriplegic after her cervical collar was removed, as she suffered a dislocation at C6 and C7. And what this really pointed to is the fact that it was a protocol violation for not being able to visualize this part of the lower cervical spine. And in fact, this is really the gist of it with flexion extension views for clearance, and that these, Brian Bollinger and their group showed that the ability to actually visualize the spine appropriately with the dynamic fluoroscopy is really very low. So they only visualized the cervicothoracic junction in 2 out of 56 patients, and in 5 of 56 were they able to even see down to C6, 7. And in this, they found, in their study, they described 1 patient that they identified with dynamic fluoroscopy as a patient with an odontoid fracture, and 1 patient with significant instability that they missed. And that was this patient who, you can see, sustained a significant dislocation below what they were able to visualize. So I think that the message here is that beyond being typically inadequate and potentially hazardous, these are not actually really necessary. And the reason for that is because CT has evolved during this period of time. And in fact, this comparison between dynamic fluoroscopy and 3D CT showed that really in 275 patients who underwent CT or dynamic fluoroscopy after having a normal helical CT scan, the number of injuries detected by dynamic fluoroscopy was 0. Now, of course, we all recognize what we're looking for with this type of dynamic exam. We're looking for ligamentous types of injuries, and of course, we all recognize that we have a different way to test this. And so has this become the gold standard for clearing the C-spine in the obtunded patient, MRI? I think that one of the things, and this allows me to kind of just really focus on things that are really being published in the last year. So this is a meta-analysis that was just done by Paul Anderson on MRI for clearing the cervical spine in blunt trauma. And they looked at, in this fairly extensive meta-analysis, in 5 studies, 464 of these patients with negative or equivocal plane radiographs undergoing MRI within 72 hours. The false negative rate was 0. So there were no injuries that were missed with MRI. The interesting that came out of this also was the number of true positives. So 97, or approximately 20%, had an injury identified on MRI that was not detected on their X-rays or CTs. Now mind you, many of these papers are from the 90s where they didn't have helical CT scanning, so that probably is one of the reasons for that. But that, of course, brings us to the million-dollar question. And that million-dollar question is contemporary CT scanning sufficient for clearing the cervical spine in the obtunded patient? And the answer to that is that there appears to be increasing evidence that it might. So this is a paper that was just published a few months ago by David Okonkwo and his colleagues from Pitt. And the conclusion is MRI is unnecessary to clear the cervical spine in obtunded comatose trauma patients. This was a study of 180 patients, the GCS less than 8, normal helical CT scanning. They identified 38 patients, though, in this series with acute traumatic findings on their MRI. 16 ligamentous injuries, some disc herniations, some hematomas. This was the table of the ligamentous injuries in this study. And it is interesting that one of these, for example, this one that had an ALL plus posterolateral complex disruption was noted and was not considered to be unstable. But in their mind, they did not consider these to be unstable. And in a retrospective review of these patients, none of them went on to requiring surgery. Their conclusion, therefore, was, as their title said, MRI is unnecessary to clear the cervical spine in obtunded and comatose trauma patients. And that was followed up by this study. This is a study from the esteemed Harborview Medical Center. This was a cervical spine clearance protocol that was developed, that was performed here. And the clearance protocol was to perform an upright X-ray if the CT scan was normal. They found one cervical cord contusion that was missed with CT, but there were no new injuries detected by upright X-ray. They did delay the spine clearance, however, by 2.6 days. They concluded that the present study adds to the accumulating body of evidence that CT alone is adequate to clear the cervical spine. It is interesting to ask this question about this 2.6 days. What's the big deal about this 2.6 days? And why not just MR them? This was a literature review that was just done to try to define some of these risks of doing the MRI in patients that had negative CTs. So they concluded in this review that the risks of doing an early, just removing the collar without the MRI was about 2.5% for cervical instability. The risk of prolonged cervical collar use included significant increases in intracranial pressure, increased ICU complications. The risk associated with transport to the MRI, these patients had an increased rate of secondary brain injury events. Up to 51% transferred out of the ICU suffer hypoxia, hypotension, intracranial hypotension. And even the lying of the patient flat for their MRI increases the ICP and the incidence of ventilator-associated pneumonia. So are the risks of neurologic injury outweighed by the risks of clearing the cervical spine in MRI? And this is a patient that we saw as a thoracic injury, multi-trauma, ped struck, and she had a number of severe injuries and was completely impossible to examine. This was her CT scan, and it was deemed normal, and everything about this cervical spine outside the spondylosis would suggest that it's pretty normal. Her MRI, however, showed that she had sustained an occipital cervical dislocation, and her Harris lines are normal. Her Harris lines are normal. So she was taken, and in fact, in the operating room, a distraction of her cervical spine confirmed that she in fact had a dissociation across here. And you can imagine what the consequences here would have been of clearing her cervical spine with her CT scan alone. So I'll conclude by saying the scientific literature is telling us that dynamic fluoroscopy really has no role in cervical spine clearance, that MRI can give you strong reassurance that a significant injury is not present, although there are some risks in severe TBI patients to taking them for that. And contemporary CT scanning is very likely to rule out a major injury that would cause the patient harm, although not always. Because our clinical experience tells us that in the end, you just got to be careful. Thank you.
Well done. Thanks to Dr. Kwan for an excellent presentation, followed by another one which I think we're going to enjoy as Dr. Wren comes to the podium. Dr. Wren has been kind enough to fly in from Philadelphia to speak to us. He's at the Rothman Institute, of course, well known for their work on spinal cord. We've asked you to talk to us about classification of spinal injuries and the concept of severity scales, which I think is a big part of the work which is being done at the Rothman Institute. Dr. Wren.
Thank you, and thank you very much for having me here today. I'm going to talk to you today about classifying spinal injuries and what role the severity scale plays in those classification systems. Now, historically, spinal trauma classification systems have used multiple numbers or letters that are often difficult to recall. And they're often complicated and useful in research and comprehensive, but often not clinically useful. In regards to cervical and thoracolumbar spinal trauma, there are benefits to be gained from a universally accepted system that can guide discussion, treatment, research, and prognostication. Now, the downsides to a severity scale are that the accuracy is always in question. Information is inevitably lost when communication is performed through using a single number, because there's inherent variability between individual patients and injury types which cannot be accounted for. So turning to thoracolumbar classification systems, there are a number of systems historically that have been published, including systems that are based on the anatomy of the spine and systems that are mechanistic in nature. In 2005, the Spine Trauma Study Group described the thoracolumbar injury classification and severity scale. It was based on the three primary axes of morphology of injury, which is determined from the imaging studies, integrity of the posterior ligamentous complex, and neurological status of the patient. The injury morphology is described as compression, distraction, or translation rotation. Now, the posterior ligamentous complex serves as a tension band posteriorly in the spine. It's composed of the supraspinous, interspinous ligaments, the ligamentum flavum, and the facet capsules, and it protects the spine from excessive motion. In the adult patient, the posterior ligamentous complex has poor healing capability once it's injured, and once injured often requires surgical treatment due to the instability that it imparts on the spine. The neurologic status is an important indicator of the severity of spinal column injury. And as part of the TLIC system, it is described as intact, as a nerve root injury, as a complete spinal cord injury, an incomplete spinal cord injury, or cauda-equina syndrome. Now, in regards to treatment, the TLIC system proposes a severity score, which is based on the 3 primary categories of this classification system. And this is the point system. In regards to morphology, a compression fracture is assigned 1 point. If there's a burst component, it is assigned an additional point. Translation rotation injury is assigned 3 points, and a distraction injury is assigned 4 points. In regards to the neurologic status of the patient, intact is 0, nerve root injury is assigned 2 points, both complete injuries also assigned 2 points, and both incomplete spinal cord injury and cauda-equina is assigned 3 points. In regards to the posterior ligamentous complex, it is evaluated by the preoperative imaging studies, including X-ray, MRI, CT scan. Intact is assigned 0 points. A suspected or an indeterminate PLC injury is assigned 2 points, and an injured PLC is assigned 3 points. And then you add the points up, and injuries with 3 points or less most likely can be treated non-operatively. Injuries with 5 points or more most likely require surgery, and then injuries with 4 points is somewhat of a gray area. You take into account clinical qualifiers, particularly in those patients who have a score of 4, but in all patients, and these include any systemic problems like ankylosing spondylitis or metabolic bone disease, multiple trauma patients, medical comorbidities. These may turn a non-operative case into an operative case and vice versa. As an example, this patient has a burst fracture. For the morphology, it's assigned 2 points. He's neurologically intact and has an intact posterior ligamentous complex. So this patient has a score of 2 points and is treated non-operatively in a brace. This patient has a burst fracture, which is assigned 2 points, who's neurologically complete and has a PLC disrupted for a total of 7 points. The patient requires operative treatment. Several studies have been performed that show that surgeons who use the severity scale in the classification system to evaluate injuries agree over 90% of the time with the treatment recommendations derived from the severity scale. Thank you.